Hello and welcome to A Dietary Debacle, a case of severe lactation ketoacidosis with ketogenic diet in a breastfeeding mother. This is Captain Christiansen speaking. The authors of this presentation have no significant financial disclosures, and the views expressed herein are our own. As an introduction to a case on ketoacidosis, we will review a few key concepts. Ketoacidosis can be caused by a low-carbohydrate, high-fat diet when significant physiologic or pathologic stressors are applied to the body. The goal in most keto diets is to consume less than 50 grams of carbohydrates to induce a ketotic state for weight loss. Lactation in nursing mothers creates a significant increase in the metabolic demands placed on the body. Women in the United States military are in a unique position to attempt expedited weight loss postpartum due to mandatory height and weight standards. Approximately 60% of active duty mothers do continue to breastfeed at the 6-month postpartum mark. The following case details the effect of combining lactation with a strict adherence to a ketogenic diet that was seen on a postpartum woman. This is our case presentation. Our case centers around a 34-year-old G2, now P2, who is 5 months postpartum, who presents to the emergency department with complaints of nausea and vomiting for 24 hours. The evening prior to presentation, she developed a severe, throbbing, but dull headache that involved the entire head with associated photophobia. She reports a generalized weakness and fatigue for several days. She has been able to maintain her breastfeeding status during her illness and has maintained her milk supply. The only significant change she can report is a 4-day history of a strict ketogenic diet with a 50-gram carbohydrate restriction. Her only notable history on review was a diagnosis of gestational diabetes type A1 that was dietary controlled during her most recent pregnancy. She reported excellent glycemic control by monitoring of carbohydrate intake and blood sugar values. During her pregnancy, she consumed between 150 to 300 grams of carbohydrates per recommendation of a nutritionist. This chart is a review of the weight trends of our patient. Her pre-pregnancy weight was 52.8 kilograms, and her maximal pregnancy weight was 69.3 kilograms. At the 5-month postpartum mark, she maintained a weight of 63.6 kilograms, an increase of approximately 11 kilograms compared to her pre-pregnancy weight. During her ER course and admission, she obtained several labs and imaging studies, the most notable of which are a CT brain and CT angiography of the brain and neck, which both returned normal, effectively ruling out vascular or mass effect causes of her symptoms. Her pH values returned at 6.99 with an anion gap of 23. This represented a high anion gap metabolic acidosis. Her blood glucose value was 81 milligrams per deciliter, and her HbA1c was 5.3%, which did correlate to her reported good glycemic control. Interventions applied to this patient include 1 liter of isotonic bicarbonate and 1 liter of D5 half normal saline. With these interventions, her pH corrected within 6 hours, which was closely followed by closure of her anion gap. When her gap closed, she was transitioned to oral bicarbonate with a maintenance rate of IV fluids, and her electrolytes were only replenished as needed. This graph represents the lab correction rates over the first 6 hours of admission. As you can see, both her pH and her bicarb level returned to normal values within the first 6 hours. Our case resolves within 24 hours as our patient was able to progress to oral intake without nausea and vomiting, and her physical exam remained normal. She was able to continually breastfeed during her admission with the assistance of a hospital-grade breast pump, and she was released for discharge to home with her family. Discussion of our case centers around the popularity of ketogenic diets in pop culture. Ketogenic diets work by inducing weight loss, shifting from an anabolic to a catabolic state. This uses up the glycogen stores and secures energy from fats instead of from glucose. In this ketotic state, the body is able to buffer the increase in acidic ketone bodies and maintain a normal physiologic status. Lactation can exacerbate this process, leading to the rapid production of acidic ketone bodies that can exceed the body's ability to buffer. Accumulation leads to a ketoacidosis state and end organ damage if left untreated. Common causes of ketoacidosis traditionally include diabetic ketoacidosis, binge drinking of alcohol, and starvation ketoacidosis. Lactational ketoacidosis is a very rare diagnosis of exclusion, and review of literature demonstrates less than 20 cases reported as case reports. In our case, our patient was likely meeting her caloric goals, but was not meeting the carbohydrate demands placed on her body by lactation. Once glycogen stores were depleted, her body started breaking down fatty acids into acetyl-CoA at a rate that overwhelmed her normal metabolic process. Instead of using the acetyl-CoA in the Krebs cycle, the substrate was shunted into the ketogenic pathway, and acetyl-CoA was used to produce ketone bodies, which caused ketoacidosis rather than her goal of a ketotic state for weight loss. The military application of this case is important. The average weight gain of active duty pregnant females is approximately 40 pounds, with ranges reported between 15 and 80 pounds on average. There is a significant expectation placed on these women to rapidly return to pre-pregnancy fitness and weight by mandatory height and weight standards. Counseling for safe weight loss methods should be provided to all active duty service members and to their civilian counterparts. New guidelines regarding postpartum soldiers are coming soon with the implementation of the ACFT. Our scholarly question was whether low carbohydrate diets while breastfeeding increases the risk for lactation ketoacidosis. We concluded that lactation is a unique metabolic state that is frequently seen in our family medicine patients. As diet trends change, it is important to be aware of the potential impact on breastfeeding mothers. Given the potential for lactation ketoacidosis in restricted diets, rapid identification of an underlying pathologic process and treatment of that process is crucial to optimize patient outcomes. A very low carbohydrate diet would not be recommended in a lactating mother, as this could increase her risk of ketoacidosis. This is a list of our references, and we look forward to your questions.